I want to share with you one of the most interesting cases we've encountered recently. This is a woman that was referred to us with corneal endothelial decompensation with a history of a phakic ICL in her right eye. And the story is she had an iris fixated varicose PMMA IOL in the anterior chamber for a long time. And she was happy with it. She was a high myope and she was doing well. But then she got hit in the eye, and the ICL, this phakic IOL, dislocated. So she had to have surgery in which that lens was removed from the eye, and it was replaced with a Visian star ICL in the posterior chamber behind the iris. But there was some problem with the lens at that point. The lens was too big, or there was some problem with how it was sitting in the eye. So she had another operation to exchange that ICL for a smaller one. And all of these surgeries seemed to have gone well, and they were done by very expert doctors, but the result after all of these procedures is that she ends up with unilateral corneal endothelial decompensation with an ICL in the eye. And the question is what to do for her. Meanwhile, in the contralateral eye, she has this ICL, she's seeing great, she's happy. So she's referred to us, and we'd like to fix the cornea of her right eye, but the question is how to do it. What surgical technique should we employ? And should we remove the ICL at the time of the operation, or should we leave it? Now, the reason to leave it is she's a high myope. And if we take the ICL out of the eye, then she's going to be a -10 again. And then she's going to have another surgery to put the lens back in, or she's going to have to wear a contact lens in the eye, which she doesn't want to do, or she'll have to have clear lens extraction, which is a significantly more involved operation. So we don't want to do that. We'd like to leave the lens inside the eye if at all possible. But the question is it possible to do? Can you do DMEK in a phakic eye with an ICL behind the iris? And that's the question we tried to answer for ourselves. This is a surgical video of this procedure that we performed just a couple of weeks ago in our office. We do all of our procedures, no matter how complicated, we do them basically in our office-based operating environment in our clinic. We love doing it that way because it gives us unparalleled control over the instrumentation, over the environment, over the staffing, over all of the critical ancillary elements of the operation. So she starts with this myotic pupil and a very edematous cornea. The anesthesia we're employing is 1 cc of subtenon's Exparel. That's a liposomal formulation of bupivacaine. The advantage of this sort of delivery vehicle for the bupivacaine is it means the block lasts 3 days. So it keeps these patients comfortable over a longer period of time. With the anterior chamber maintainer on now, this is connected to a 60 cc syringe, which is held by my assistant. He's depressing the butt end of that syringe, and that's inflating the anterior chamber. And you can see how much posterior pressure. The bubble really doesn't want to extend out to the periphery. And I'm having to sort of fight this eye in order to keep the anterior chamber maintained. And you can see how invaluable it is to have this AC maintainer in order to keep an airfill of the anterior chamber. There are lots of surgeons who do their descemetorrhexis under BSS or under viscoelastic, and often that works fine. But when you have a really complicated case, I think that you really want to see as well as you possibly can. And your visibility is better under air than it is under any other medium. And for me, most of the time, the longest, the most challenging, the most difficult part of the surgery is the descemetorrhexis. That's the thing that I struggle with the most. And so in order to make that part of the surgery as easy and effective as possible, I like to use air. The other thing you'll notice is I make a couple of paracenteses, and I'm using the inverted Sinskey hook, I'm using the Mella scraper, and I'm using coaxial forceps to reach in from different vantage points and sort of sneak around the periphery of the eye, looking for little remnant, tattered shreds of Descemet's membrane. I'll move the anterior chamber maintainer to a new paracentesis, and that frees up the area around the previous paracentesis in which that AC maintainer was located. It just lets me get better access to the eye. And once that's done, Now I'll make my peripheral iridotomy. So I'll switch this AC maintainer to BSS. This is an earthly capsulorhexis handpiece. It cauterizes a hole in the iris, and that lets me make a good controlled far peripheral iridotomy with no bleeding. Now I'm injecting the graft into the eye. And the first thing I want you to observe is that the pupil has become quite large during this case. And I think that this is because of the subtenon's block that I administer. I think if you get a good block, sometimes you get this reflexive pupillary dilation, and that is helpful when you're doing an operation that involves dilating the pupil, like for example, cataract surgery. But in this particular case, it's not helpful. A dilated pupil makes the surgery more difficult to perform. So this is probably one reason not to do a subtenon's block for all or your routine cases, or at least to have myocall or myostat on standby, because if you can constrict the pupil, it sort of shallows the chamber a little bit. It evens the anterior chamber diaphragm, so it's easier to unfold the graft. Plus, it prevents the problem that we were about to encounter, okay? So you'll notice I've got this giant graft in the eye, okay? And the first step always is we remove the air bubble from the anterior chamber. And you'll notice there's still one up at 12 o'clock, so I'll remove that bubble. And now the graft is curled. I'm gonna inject some BSS to try to get it to declare itself, to open up a bit. But you'll notice I'm getting iris prolapse from the main wound. And this is the key issue that I have to deal with in this case. Is I have a big graft. This is bullous keratopathy, so I'm needing to use a large diameter graft. This is a 10 millimeter graft. But the thing is, in order to open this graft, you have to deepen the chamber. You have to inject balanced salt solution. But when you inject fluid into the AC, this is a cramped confines eye. You have to worry about pumping up the pressure and then getting iris prolapse or graft ejection. So you'll notice the way that I am doing it is I'm trying to flush and flip the graft in the eye through the main wound. I'm depressing the main wound and I'm irrigating through the main wound. And that is something that I think is a little bit taboo when you're doing DMEK surgery. There are lots of surgeons who say never irrigate through the main wound or always suture the main wound as soon as you put the graft inside of the eye. But there's a concept here that it was actually taught to me by my dad. I remember when I was a resident and I was learning cataract surgery and I was doing my hydrodissection, that's when I would always get iris prolapse. And I was complaining about this to my dad, and he said, well, the reason you're getting that is because when you're doing hydrodissection, you need to be depressing the main wound when you're injecting. And that allows the fluid to circulate around inside of the eye such that the pressure doesn't build up, because it's the pressure building up that ejects the iris through the main wound. So if you're burping the main wound while you're doing your hydrodissection, you'll get this current that flips behind the lens, but you won't jack the pressure up inside of the eye. And it's the same way here with flipping and flushing the DMEK graft. In order to get this graft to unfold, to flip, to tumble, to move in the AC, you've got to inject fluid. But if you inject through a paracentesis, timidly, you're just going to build up the pressure in the eye and you're going to squirt the iris out. But if you're pushing on the main wound while you're injecting BSS, you're going to create a current that flips the graft over, but you won't build up pressure inside of the eye. And that is a scary thing to do, to burp the wound while you're vigorously injecting fluid and thinking, God, the graft is definitely going to come out, but it doesn't, okay? And that was the key thing to solving this case. Now the graft is in this bouquet configuration. I'm going to check the Motsuro sign to make sure it's right side up. That's a positive sign. The tip turned blue. So now we shuffle the graft over, and now we use the best technique in all of DMEK surgery for graft unfolding. That's the Dirazomer technique, in which you use 2 cannulas, one to pin the graft and one to tap on the bleeding edge of the tissue to move it over. So now here the graft is in the eye. It's sort of decentered. In order to shift the graft over, you always have to put more fluid inside of the eye. So I'm putting some more fluid that lets me mobilize the graft over, and these are just a few little shuffle bumps. And you'll notice over temporally, kind of close to me, down at the bottom of the screen, there's this triangular wedge of the tissue cut out. That's my orientation mark. It's half of an arrowhead, and it points around clockwise, and that clockwise point indicates whether the graft is right side up or upside down. So it should be pointing clockwise, and that indicates the graft is right side up. And that's the end of the operation. So the reason that I show this case, the sort of learning point for me, was how in the world are we going to do DMEK in this eye that is not just shallow in the sense you have a phakic eye, but it's a doubly shallow anterior chamber because you also have this phakic ICL. And as I've mentioned in this channel before, people think of the hyperdeep chambers, the post-vitrectomy, the ACIOL, the scleral fixated lenses. People think that those are the difficult DMEK cases, but it's actually the shallow anterior chambers that are the most difficult cases for DMEK unfolding, because in order to unfold the graft, you got to deepen the AC. And there are frequently things that prevent effective deepening of the chamber, like anterior synechia or an ICL. So how do you manage that? Well, the key for this procedure, the reason we were able to do this procedure effectively was because, number one, we had the proper instrumentation. We're doing the operation in our office, okay? So we have all of the very best tools and equipment and staff right there, which help us maximize the chance of our success. But second, it's sort of the concept of what to do in a situation like this. The graft is upside down, or it's wadded, or it's scrumbled, and you can't really deepen the chamber because you're getting iris prolapse. How do you unfold the graft? Well, it's by injecting fluid while depressing the main wound. That's the way you get the graft to open up, even if you can't really profoundly deepen the chamber by pumping it up with fluid. I could have made the surgery easier for myself if I had injected myostat into the anterior chamber when I recognized there was that big dilated pupil. So even here, there is room for improvement. And that's sort of the last point that I would make is, one of the reasons why I make these videos is because we do interesting cases that other people find interesting, and we sort of want to share the insights that we have. But the other reason is we make these videos for ourselves. I make these videos for me because I learned so much from watching my own cases. And if you're not recording your own cases and watching your own cases, there is this huge opportunity that you're probably losing out of to teach yourself, so to speak, to watch and see what works and what doesn't work, what seems to be effective and what seems to be ineffective. So if you take one thing from this video, even more than how to do DMEK in an eye with an ICL, it's how to learn from your own cases, which is by watching all of your own videos.